So welcome guys. In today's session, we'll be discussing about asthma and give me a minute. You look at the pathogenesis of asthma, the variants of asthma, morphology of asthma, and clinical features of asthma. Welcome all. My name is Wallace Munyiri, and I'm the redactor now. Asthma, what is it? It is simply a chronic inflammatory disorder of the airways, and it is characterized by recurrent episodes of wheezing, breathlessness, chest tightness, and cough. And these mainly occur at night or early in the morning. Now, hallmarks of asthma. It is characterized by intermittent reversible airway obstruction. So note it is reversible. There is also chronic bronchial inflammation with eosinophils. Okay, so eosinophils. There is also bronchosmooth muscle cell hypertrophy, okay, and hyperreactivity or hyperresponsiveness. Also, there is increased mucus secretion, okay. So if there is increased mucus secretion, you expect the number and the size of the goblet cells will be increased. So there'll be goblet cell hypertrophy and hyperplasia. Now, the cells that play a role in that inflammatory response include the eosinophils, mast cells, macrophages, lymphocytes, neutrophils, and the epithelial cells. Now, recently, there has been an upward trend in the number of cases of asthma in the Western world. And this can be explained using the hygiene hypothesis, which states that due to a lack of exposure to environmental microbes at an early age, children who live in environments which are extremely clean or due to lack of that exposure, their immune system is not trained at an early age. So once exposed to harmless antigens, the immune system overreacts. So it like overreacts. So there is a hypersensitivity reaction. Okay, so that has been said to be the reason why there's an upward trend in the number of cases of asthma in the Western world. Now, in a normal lung, the bronchi, this is normal. Okay, you can see normal amount of mucus and the muscles are usually relaxed. But in an asthmatic lung, the muscles are usually tight and swollen lining, okay, and with excess mucus production, and you can see broncho constriction, but this is reversible. Now, how the pathogenesis now. Asthma is a type 1 hypersensitivity reaction, okay? So note that. Now, okay, let me first skip this if you allow me. We will go back there later. Okay, this is what happens. There is a sensitization phase, okay? During the sensitization phase, the patient the patient will inhale an allergen like a pollen, okay? Then this allergen is taken up by the dendritic cells and presented to the T helper 2 T cells, okay? So upon presentation, the helper 2, the T helper 2 cells secrete the following cytokines: interleukin 4, interleukin 5, and interleukin 13. Now, interleukin 4 and interleukin 13, especially interleukin 4, will enable IgE class switching, where the B cells will produce immunoglobulin E, which will bind to the FC receptors on the submucosal mast cells. Okay, then interleukin 5 will participate in eosinophil activation. Okay, and also interleukin 13, which is also produced, will cause mucus hypersecretion of excretion of a secretion of mucus. Okay, then upon the now that was the sensitization phase. When the patient is first exposed to the allergen, they will not present those the classical signs and symptoms of asthma. But upon re-exposure, there will be a cross-linking of the immunoglobulin E, crossing degranulation of the mast cells. And this degranulation of the mast cells will lead to the immediate phase of the early phase, which is later followed by the late phase. Okay, so let's go back. There we are. Now, this is what I've been summarizing. Okay, now in the early phase, there will be bronchoconstriction, increased mucus production, and vasodilation. Now, this bronchoconstriction is due to the mediators released from the mast cells, and these include histamine, prostaglandin D2, and the slow-reacting substance of anaphylaxis, which include leukotrienes C4, D4, and E4. Also by the reflex neural pathways, the vagal neural pathways, okay? Now, the red phase reaction is inflammatory in nature. Now, the inflammatory mediators usually stimulate the epithelial cells to produce chemokines, especially eotaxin, and which is a potent chemoattractant and activator of eosinophils. And this will promote the recruitment of T helper 2 cells, eosinophils, and other leukocytes. And this will amplify the inflammatory reaction that was initiated by the resident immune cells. Okay, so this is what in the early, this is there'll be bronchoconstriction, you can see mucus hypersecretion. Also there'll be increased vascular permeability and an edema, and also there'll be a reflex, the vagal, there'll be a reflex pathway, okay? And in the red phase, it is mainly inflammatory in nature, okay? So I want to, now this is a normal lining. You can see some changes between, this is a normal lining and this is in asthmatic patients. You can see here there is increased mucus production, expand here compared to there. Here you can see the basement membrane is thin, but here you can clearly see it is weak because there will be subepithelial collagen deposition. You can see the glands here, okay? They have undergone hypertrophy here and hyperplasia. Also, you can see the smooth muscles have undergone hypertrophy, okay, and hyperplasia. Now, this is just what I was saying, okay? So, airway remodeling. Now, when there is those repeated bouts of inflammation, there'll be structural changes in the bronchial wall that are collectively known as airway remodeling. Now, this will include weakening of the airway wall, subbasement membrane fibrosis, increased submucosal vascularity. Also, there'll be increase in the size, okay, of the submucosal gland and goblet cell metaplasia of the airway epithelium. Also, there'll be hypertrophy and or hyperplasia of the bronchial muscle. So these are the what constitutes the airway remodeling. And here you can see this diagram where you can see there is clearly here the basement membrane. There is subepithelial collagen deposition. Okay, so there is epithelial fibrosis, and the smooth muscle cells here have undergone hypertrophy and hyperplasia. You can also see an inflammatory infiltrate. Okay, so this is what constitutes airway remodeling in seen in asthma. Now, the variants of asthma have two variants: extrinsic asthma and intrinsic asthma. Now, for extrinsic asthma, let's start with extrinsic asthma. It is a type 1 hypersensitivity reaction due to exposure to an intrinsic antigen. It presents, age of presentation is in children. There is a positive family history. So that tells you there is something to do with genetics and interleukin 13 gene polymorphism, and another gene known as ADAM33 have been implicated in the inheritance of this form of asthma, okay, ADAM33. Also, there is a positive history of allergen exposure with rhinitis, urticaria, and eczema. The serum IgE levels are elevated. When you do an intradermal skin test with the allergen, there will be the wheel and flare reaction. So skin test, a positive one. It is rarely associated with COPD, the chronic obstructive pulmonary diseases. And examples of extrinsic asthma include atopic stroke, allergic asthma, occupational asthma, also allergic bronchopulmonary aspergillosis. Now, intrinsic asthma, it is initiated by non-immune mechanisms with intrinsic body stimuli. It presents mainly in adults. there is no family history, and there is no prior exposure to an allergen, the serum IgE levels are in fact normal. And when you do a skin test, it will be negative, but it is associated with COPD. Okay. Now, drugs, we have what is known as drug-induced asthma, especially patient with aspirin. Now, what will aspirin do? Remember, aspirin will inhibit COX, cyclooxygenase. Now, if cyclooxygenase is inhibited, arachidonic acid will undergo will be acted upon by the lipoxygenase. We'll go to the lipoxygenase pathway, and remember the eventual products of the lipoxygenase pathway are the leukotrienes, which are especially leukotriene C4, D4, and E4, which are the slow reacting substances of anaphylaxis. Now, viral infections, okay, viral infections usually reduce the threshold of the subepithelial vigor, vigor receptors to irritants, also cold exposure and exercise-induced asthma. Now, during exercises, you lose water and heat due to that heat from the respiratory tract, and that will lead to mucosal hyperosmolarity. Now, due to that mucosal hyperosmolarity, that will trigger the mast cells to release the mediators, and that will now induce the exercise-induced asthma. Now, morphology. These changes have been described in individuals who die due to prolonged severe attacks, or patients who have what is known as status asthmaticus, or in mucosal biopsy patients of individuals who are challenged with allergens. Now, in fetal cases of asthma, the lungs are usually distended due to overinflation, and there may be small layers of atelectasis. Now, the most striking finding in is the occlusion. There will be occlusion of the bronchi and the bronchioles by thick, tenacious mucus plugs. Now, when now you correct sputum, which is now emanating from these mucus plugs, you expect to find the 3 C's. Please remember the 3 C's of asthma. These C's of asthma. 1, you will see holes of shed epithelium, what are known as Cashman's spirals. You will also see the cathode-laden crystals, and these are crystalloids which are made up by an eosinophilic protein known as galectin-10. Okay, you will also see what are also called cleolar bodies, and these cleolar bodies are simply individual epithelial cells. So please remember those 3 C's: Cashman spirals, cathode-laden crystals, and the cleolar bodies. So here they are. These are the Cashman's spirals. Okay, you can see it's a spiral. Here you can see the cathode-laden crystals made up of galectin-10 from the eosinophils. You can also see an eosinophils and the polymorphonuclear neutrophils. Okay, and this is a sputum. Okay, now clinical features. There'll be a severe dyspnea and wheezing due to that bronchoconstriction and mucus plugging, and this will lead to trapping of air in the distal air spaces and progressive hyperinflation of the lungs. Now, in usual cases, the attack usually lasts from 1 to several hours and subside either spontaneously or with therapy. Now, the intervals between the attacks are characteristically free from overt respiratory difficulties, but persistent subtle deficits can be detected on pulmonary function tests. So these asthmatic patients have paroxysms, okay? So they have attacks, but between those attacks, they are characteristically free from overt respiratory difficulties unless you do a pulmonary function test. That is when you detect persistent subtle deficits. Now, occasionally, a severe paroxysm or attack occurs and does not respond to therapy and persists for days, even weeks, and that is now what is known as status asthmaticus. And the associated hypercapnia, acidosis, and severe hypoxia in status asthmaticus may be fatal, but in most cases, the condition is more disabling than lethal. Okay, so therapy, but this is now more of pharmacology. So I just go through this very fast. Anti-inflammatory drugs, as particularly glucocorticoids, are useful. Beta adrenergic drugs, especially such as salbutamol. Okay, leukotriene inhibitors have such as montelukast, zeutolone. Okay. Now, also agents that block specific immune mediators such as interleukin 4 and 5 are of modest benefit in some patients, but they are not broadly efficacious because asthma is a disease which has it exhibits heterogeneity. Okay, so we don't have like a common pathway because remember I told you intrinsic and extrinsic asthma. In intrinsic asthma it is so in intrinsic asthma this might not be implicated. Another approach is called bronchiodermoplasty, and where we have the controlled delivery of thermal energy to the bronchi, okay, and this will reduce the mass of the smooth muscles and airway responsiveness, and this has been evaluated in patients with severe uncontrolled asthma, the status asthmaticus. So that's that. I think it was that easy, and thank you for attention, guys, and please subscribe for more of my content. Thank you very much.